Thank you. So, I was tasked with dealing with some oral surgery topics, and specifically anti-resorptive osteonecrosis of the jaws, or the synonym medicine-related osteonecrosis of the jaws, and odontogenic cysts. I've already delivered a lecture on odontogenic cysts earlier in the program, and again following the idea of sort of selling the 5 top tips, if you like, for each subject area. So in terms of osteonecrosis, you can see it's not a new condition. This is a photograph of an early Edwardian matchstick maker, and they used to use white phosphorus for matchsticks. And so they were otherwise young, fit and healthy, male and female, and they developed osteonecrosis at that stage with the phosphorus-related damage to the bone. So it's not a new condition. It's just reared its head again in another format. The first and probably the main tip here is read. You'll get the answers from these 2 publications. The American Association of Oral Maxillofacial Surgery position paper, and laterally the Scottish Dental Clinical Effectiveness Programme, Advice on Oral Health Management of Patients and Prescribed Anti-Resorptive and Anti-Angiogenic Drugs. The latter is very good, and I would highly recommend it. So in terms of preparing for the exam, I think if you read both of these, you'd know all you ever needed to know about osteonecrosis of the jaws. We'll talk a bit about the definition, the pathogenesis, signs and symptoms, staging guidelines, and assessing the risk. Because of course your life in clinical practice is all about assessing risk. It's not to be risk averse. It's not to run away from a problem. It's to actually assess the risk and get on with managing it. And we'll touch on some other related issues. So for patients to be considered to have osteonecrosis of the jaw, they must have clearly been on previous or current treatment with the anti-resorptive drug, stands to reason. They must have persistently exposed bone for more than 8 weeks. They mustn't have a history of radiotherapy or obvious metastatic bone disease. And this can occur with treatment with both bisphosphonates and drugs such as denosumab. There's a fair amount of debate, as you're probably aware, in relation to the pathogenesis of this condition. There are various schools of thought. Like everything in life, it's probably a combination to some extent of all of these features. So inhibition of bone remodeling, particularly centered around the jaw bones. Inflammation and infection, secondary to the fact that we have teeth in the mouth and facilitate ingress of bugs through those. Anti-angiogenesis medication having an effect directly on the soft tissue and the soft tissue covering, and wound repair, soft tissue toxicity, and some form of immune dysfunction as a result of the medication. So all of these are probably at work to a greater or lesser extent. Signs and symptoms are protean in their presentation. They can range from being painful, although in my experience simple exposed bone doesn't tend to be painful in these circumstances. The pain comes from collection of pus where the bone has become infected. Swelling and sinus formation, both intraoral and extraoral, bad taste. If the osteonecrosis is extensive, you can expect the patient to develop numbness in the distribution of the sensory supply, clearly in the mandible in particular, or paresthesia, and delayed healing following extractions is not uncommon. And this can be very subtle. So you see before you a range of pictures showing various degrees of this slowness to heal. So you might consider this just simply a dry socket unless it's about 8 weeks old. And then it's not a dry socket anymore. There's something not right here. It could be in the edentulous scenario, a simple, very small area of exposed necrotic bone, such as here. And then where you have perhaps undertaken a clearance, if I was to tell you that this latter picture is about 2 months old, is that normal? And the answer is it's not. There is epithelial mucosal coverage, but the sockets haven't remodeled. because the osteoclasts aren't working. So you're not getting that saucerization and eventual removal of the sockets. The sockets are still there, but they're covered. That would be a good result. I'd be very happy if I got to that level with these patients. And then you can get a bit worse. You can get extensive necrosis, in this case in the maxillary region, even more in this particular photograph. But you can also get collections of pus around necrotic bone, which then drain, in this case extraorally, and mimic to a large extent dentoalveolar abscesses. And that's where the pain and the problems can set in. This is a CT scan of a patient that I recently saw, and it highlights very well this idea of casket formation, where the dead bone in the middle is incarcerated. This is the dead bone here, is incarcerated with new bone which is being laid down, because remember, the osteoblasts are working away feverishly, but the osteoclasts aren't, and so the dead bone is still left behind. And so in many regards this fits the old picture of osteomyelitis, chronic suppurative osteomyelitis that you would have come across. And of course, don't forget that these patients are on these medications for a reason. In this case, this was a patient with myeloma and was being managed. But also, look at the C-spine here. This is not a good patient to put to sleep on an operating table to fix the osteonecrosis of her mandible, because she only has to be flexed a little bit and she'll wake up a tetraplegic. So these things have to be borne in mind when you're dealing with these patients. Tip 2 and 3, make sure you match the stage of the condition to the treatment. So understand the stages from no clinical evidence of necrotic bone here, no specific clinical findings, radiographic changes and symptoms right down to stage 3, and be able to associate or map the treatment strategies to those. And the treatment strategies can sometimes be very disappointing. In my experience, it tends to be less is more for these patients. And working along over a period of time, you try and get them to a period of stability. And that's always in association with their physicians who are giving them this medication, which they require. But on some occasions, you can negotiate with their physicians to leave them off or give them a holiday from their medication until you reach an equilibrium. And that can be easier said than done. This panel describes the different sort of risks that each of those position papers describe. So the Scottish paper and the position paper from the American Society. So for example, the Scottish paper says if they've had a previous episode of osteonecrosis, then clearly they have a higher risk of developing another episode. Both of them will agree that in terms of bisphosphonate use, you have a much higher incidence, relatively speaking, in patients who are having the bisphosphonates because they have metastatic disease and you want to reduce their hypercalcemia. So there's a much higher incidence of 1% versus 0.1% for those that are just having bisphosphonates because of osteoporosis. The denosumab can range between 0.7 and 1.9%, and cancer versus osteoporosis, about 2.2% in osteoporosis if it's being used to manage osteoporosis. So it'd be a good idea to get your head around a few of those figures that you can quote back to the examiner. It really impresses the examiner if you have an idea of the risk associated with them. Tip number 4, as Kumara hinted at, try and sort it out before it becomes a problem. So in terms of prevention, be aware of the patients who are at risk and make sure that you explain to them that they're at risk, because everything you tell them in advance of your surgery is an explanation, and everything you tell them after your surgery is an excuse. So make sure they're on the ball about what you're planning to do and why they're at risk, and being able to quote the patient some risk numbers from the previous documents will help you. It'll help focus the minds. Oral hygiene advice then, everything you'd then do in a pediatric clinic. Stands to reason. Dietary advice, fluoride, all the rest of it. take out any teeth that need to be taken out before they start their treatment, reduce periodontal dental infection, adjust, replace poorly fitting dentures, undertake any remedial dental work. It all sort of is fairly logical. Tip number 5, after treatment, assess again the risk of the patient. Remember, the patient may have stopped taking the medication, but that doesn't mean that they're not at risk from it. And they may receive infusions that don't appear on their regular medical sheet if you have access to those electronically. The Scottish paper then goes into stratifying these patients into low and high risk, and that's self-evident. They talk about low risk being under 5 years. They talk about people being in high risk if they've been on the rank L inhibitors for any length of time or concurrently treated with systemic corticosteroids or immunosuppressants. In other words, the longer they've been on them and the sicker the patient is systemically, the higher the risk. Low risk patients then, they talk about trying to avoid extraction if necessary, but if you do need to do it, make sure that you advise the patients and make sure you follow up the patients. Try and adopt as low a traumatic extraction, or try to get the tooth out as simply as possible. But that again is easier said than done. In terms of higher risk, then again it's very important that you're going to discuss with the patient. It's very important that you've eliminated all the opportunities or options, that you've recorded that, and then clearly if the tooth needs to come out, you need to proceed with the extraction. None of these articles are recommending antibiotic cover in this regard, which is interesting. There are some differences between the two guidelines. The Americans are proposing taking a holiday from these medications, and again that's easier said than done and would require liaison with their practitioners. Other things you have to bear in mind are the anti-angiogenic drugs that they may be on, such as the tyrosine kinase inhibitors and the vascular endothelial growth inhibitors, and they're all going to be used in cancer patients to a greater or lesser extent. So if you've identified a cancer patient with systemic disease or systemic spread, then they're going to be at a very high risk. So moving swiftly onwards, cysts. 5 tips. First tip, read the book. There are 2 recommendations on that, and I'll leave you to record that. That'll be in your handout. Cyst-like lesions will tend to have a corticated margin. So if somebody's referring a cyst, a proposed cyst to me, the first thing I want to know about is the margin of this radiolucent lesion. What does it look like? And if it's corticated, then there's a chance that it's a cyst. If it ain't corticated, it ain't going to be a cyst. Number 2, not all cyst-like lesions are cysts, unfortunately. And radiographic features such as site, size, shape, anatomical relationship, particularly to the teeth, are important to record in your referral. And the diagnosis will be based on a combination of everything, not just the film. So clinical history, examination, including sensibility testing of the teeth. Don't forget to lift a bit of ethyl chloride onto the tooth, because that'll help remove a fair number of options in terms of whether the tooth's vital or not. And of course, radiographic findings. So we should all know the definition of a cyst, pathological cavity that may or may not be fluid filled, and which on the most part will contain some form of contents, normally fluid or semi-fluid. You should be familiar with the WHO classification of cysts, epithelial and non-epithelial. I intuitively don't find this an easy classification to work with. But there we are, we have to work with what we're given, and you should be across the detail of the WHO classification, because that's a fairly common question. The inflammatory epithelial cyst, we're going to talk about dental cyst, because that's the most common by a long shot, about 75%. And in terms of developmental cysts, we're going to talk a bit about dentigerous cysts and keratocysts. And in terms of the non-odontogenic epithelial cyst, we're going to talk about a nasopalatine duct cyst, because it can mimic other odontogenic cysts. But before that, I want you to be aware of what you need to be able to describe if you're showing an image of a radiolucent lesion, which may be a cyst. You need to tell us about the margin, whether it's well-defined, because you can have well-defined margins without cortication, and whether it's corticated or not. You need to talk about the quality of the radiolucency. Is it uniform? Is it mixed? Is it loculated? You need to talk about the shape, because that is an index as to what the genesis of this radiolucent lesion is. So is it circular, which might suggest expansion through hydrostatic expansion, equally in all directions, which limits the cysts that you're dealing with? Or is it elongated? Is it growing along a pathway of least resistance, which might indicate another form of growth intrinsic within the epithelium within the cyst, such as a keratocyst? You need to tell the examiner whether it's small or large. Big ones that get to the size that they are would tend to put you off an inflammatory type cyst and more to developmental or other non-cyst lesions, because they've got so large before they show themselves. And then, of course, sight. The angle of the mandible, the body of the mandible, the symphyseal region. Is it related to the apices of teeth? Is it related to the neck or the crown of an unerupted tooth? So these are all important things that you need to be able to describe when you're talking to a film. And for that, I'm going to run now through a few films. So OPT, and you can see here, this is a reasonably heavily restored dentition. There's been a bit of restorative work done. Some of these teeth have had everything done to them that could possibly be done, and some of that isn't done very well. And then we can talk about the periapical radiolucent lesions. And so they, to my mind, are not cysts. And you should be able to be in a position to say these are not cyst-like because they're not corticated, they're too small, and whilst they're in periapical relationship to these teeth, they are more than likely granulomas. Okay? So to be able to distinguish those from cysts. As we move onwards in our journey on cysts, you can see in this OPT a fairly well-defined, corticated, unilocular, circular cyst-like lesion in periapical relationship to a heavily restored tooth that I bet if you put some ethyl chloride on would be non-vital. So it fulfills the criteria of non-vitality, and therefore the likely diagnosis in that case would be a dental cyst, or radicular cyst would be the synonym. If we move on, we have a more sizable cyst here, or cyst-like lesion. It's cyst-like because it's again corticated. It's unilocular. It has a bit of lobulation going on, and it's in periapical relationship to this molar tooth and to these premolar teeth that are root-filled. So the differential is likely to be having a dental cyst at the top of it, but a sizable dental cyst. But it could be other things that you have to bear in mind. And if you were looking at that in more detail, you'd certainly want to do sensibility testing on that molar tooth. Moving onwards, another OPT, an unerupted tooth this time, a cyst-like radiolucency, cyst-like again because it's got a corticated margin. It's unilocular, but now it bears a different relationship to the tooth. It is in dentigerous relationship to an unerupted tooth. And therefore, the likely diagnosis, number one on your differential, would be dentigerous, but of course it could be other things that we'll come to momentarily, including keratocyst or ameloblastoma, which can disguise itself. But it wouldn't be unreasonable for you to walk through that film, describing it as I've described it, and putting a dentigerous cyst top of the list. Reasonable? Okay. Moving on, we now start to pick up other clues. This is a OPT. You might suspect it's of an older patient because it's partially dentate. With this, you have another cyst-like lesion with a corticated margin. Because of the superimposition of the cervical spine, it's masking the front end of this, but this lesion actually extends all the way out here. In fact, it probably goes out here. There is a suspicion that there's something maybe going on there. And the other feature that I would draw your attention to is, whilst it appears unilocular, at least the bit that you can see very well, there's something going on here that wasn't going on in the other films, which is apical resorption. So whatever's going on here, it's big, it's bigger than what you're used to, and whilst it's in periapical relationship to these teeth, these are effectively virgin teeth. There's no restorations in them. They're unlikely to be non-vital. They're likely to be vital. So there's something else here. This isn't a dental cyst, and there's resorption. So there's an aggressiveness to this lesion that isn't in the other lesions, although I have seen dental cysts that produce apical resorption. So you as a detective would be able to work your way through. You can see yourself in front of an examiner, stepwise working your way through. And each one that you're saying is really making the examiner very impressed with you. So you're going to be the next consultant. I'm spoiling the party. I'm not telling you what they are, am I? No. But anyway, we'll work on. Next one up. Now, this is kind of the territory you want to be in. Everybody wants to see the keratocystic-like lesions. It's in the right place, isn't it? It's at the angle of the mandible. It's very big. Look at its AP dimensions versus its vertical dimensions. It's grown along a pathway of least resistance. It's now beginning to adopt this soap bubble appearance. It's multiloculated, but it's still got the corticated margin. So you'd be quite right to say, well, I don't think it's a dental cyst. It could be a residual cyst, but it's a bit big and it's multilocular and it's in the angle of the mandible. What I'm left with is either a keratocystic lesion or an ameloblastoma or a myxoma, but that would be fairly high on your list of potential diagnoses. Moving on to this one, you can see again at the angle. This one seems unilocular though, but look at how much bone resorption there's been. These teeth are pretty much floating in it, but it still retains cyst-like characteristics because it's got a corticated margin. And again, the differential diagnosis would be pretty similar to the other one, except we're missing the loculation, but that doesn't mean that it can't be a keratocyst. It could be an ameloblastoma, it could be a unicystic ameloblastoma or a unicystic keratocyst. Then we start to get a bit more fiddly because here's one that's a bit elongated. It's in the front part of the mandible, not the place that you're taught about in the books. It appears unilocular, but it's got this lobulated appearance, but it's still corticated at the margin, so it's cyst-like. And its epicenter is this non-vital restored tooth. And in fact, that turned out to be a dental cyst. So you can have exceptions to the rule. You probably were galloping down the road of keratocyst, ameloblastoma, or possibly a traumatic bone cyst, but it turned out to be a dental cyst. 1 minute over because I started late. Is that okay? Thank you very much. This lady has now regrettably passed away through other cardiac issues. But she came to me in probably the first week as a consultant. So this lady fronted up. And you can see what we were doing. It harps back to what Dr. Cowan was talking about. We're testing facial nerve function because initially you look at that and you think, is there a parotid problem going on here? Then when we dug out the records, we could see that she was in 1986 and she had a keratocyst enucleated, inverted commas at that stage, 1987, 1988, and things seemed to be getting better for her. But then she was lost to follow-up and she comes back to me in 2000 and look at the size of the lesion. The whole ramus is gone, the condyle is gone, and the cornoid process is gone. That's the CT scan. Look at the multiloculation, very good. It also identifies the bony origin of this lesion, and the three-dimensional reconstruction just shows that she actually has a pathological fracture here. And we managed this through marsupialization only, and we managed to grow back a condyle, albeit in the wrong place, and a bit of the cornoid process as well. The problem with keratocysts is these issues. Very thin epithelium, so if you don't get it all out, it's going to seed the area and come back. And then these daughter cysts within the fibrous capsule. So these are lurking somewhere out here. So if you don't get the capsule out, then you have the daughter cysts, which are going to grow back. Management through marsupialization, as I say, although that takes time and it takes effort from the patient. You can get pseudocysts, for example, cavities forming in the mandible due to the position of the submandibular gland. So Staphnei's inclusion cyst. That's a wee tester that some of the more nasty examiners would throw up at you. But the trick is it's below the inferior alveolar canal. So it ain't going to be related to the teeth. Nasopalatine duct cysts, again, clinically very obvious. It needs to be in the nasopalatine area for it to be a nasopalatine duct cyst. And then you get this heart-shaped appearance because of the relative density of the anterior nasal spine. So you get this heart-like appearance to it, particularly if it's sizable. Finish off with treatment options: enucleation, marsupialization, and resection. When we talk about resection, we talk about removal of a margin of bone around the area, and we look at confining that to something like an ameloblastoma. You can either enucleate and close primarily, or you can enucleate and keep the pack put a pack in to avoid a sizable hematoma forming and maybe infection of that. But those are the 3 treatment options that you should be aware of, and they'll depend on the type of cyst, the size of it, the anatomical relationship, the age and general health of the patient, presence or absence of infection, and previous surgery. Thank you very much.